Increasing parental decision-making. Parents should be considered an essential part of the healthcare team rather than visitors. Give them the information they need to take an active part in decisions made about the infant's treatment plan. This is true even for decisions that seem insignificant to the staff. This knowledge will increase their feelings of control over a situation in which many parents feel they have little power. As parents get to know the infant better, they become experts on the infant's response to various situations and caregiving activities. Their expertise should be recognized and respectfully considered in planning infant care. Although parents often feel like outsiders when first visiting the NICU, they can, in time, move into the role of partners with the NICU staff in caring for the infant. Look for opportunities to praise parenting abilities. Point out positive ways the infant responds to the parent's touch and caregiving. Model methods to respond to behavioral cues, and acknowledge parents when they respond to the infant's signals appropriately. Listen to their ideas about what works best for the infant and incorporate them if at all possible. Alleviating concerns. Invite parents to call the NICU at any time for information about their infant. This helps allay worry when parents wake up at night and wonder how the infant is doing. Phone calls are especially beneficial for parents unable to visit the infant because of distance or other reasons. Parents also need support from others besides nursing staff. Put them in touch with parents of other preterm infants and refer them to support groups, parent-to-parent groups with veteran NICU parents, telephone support, educational offerings, or counseling sessions. Tell them about internet sources such as preemicare.org and preemeparentalliance.org. Talking with others who have faced the same problems can be very comforting as parents. Compare notes and get practical suggestions from an experienced parent's point of view. Some agencies pair parents with a buddy who has had a similar experience and is from the same culture. Special programs may be available after discharge to provide parents with ongoing support and education. It is important to consider language and culture during this process. Cultural practices should be incorporated into the care of the infant. Determine who in the family will make the decisions and who will be managing the infant's care. In some cultures, the father makes decisions and the grandmother, rather than the mother, is the major caregiver. In these cases, it is essential that the right persons be included in appropriate teaching. In many cultures, the mother is expected to stay at home to recover after giving birth. This interferes with her ability to spend time in the NICU. Another family member may be enlisted to be with the infant in these cases. Helping with ongoing problems. Parents may be unprepared for the inconsistent progress infants often make after surviving the risks of the early days. They expect steady progress once the infant can breathe independently and take feedings. However, complications such as NEC or sepsis can cause major setbacks at this time. To cope with a new crisis, parents need extensive support from the nurse. Use therapeutic communication techniques such as reflecting feelings to help them express and cope with their extreme disappointment. Give information about the infant's changing condition and what to expect in the days ahead. Having a hospitalized child can be exhausting for the parents. Remind them to take breaks away from the infant, whether to go to the cafeteria for a meal or go home and rest. As the infant's condition improves, parents may take more time away as they begin to prepare for discharge. Encourage them to do this, while making sure they feel welcome to stay with the infant as much as they desire. Mothers with infants in a NICU may have problems with sleep disturbances and depressive symptoms. Be alert for signs of postpartum depression because fatigue and having an ill infant are factors that may lead to this condition. One study found a 20% rate of depression in mothers during the 18 months after their high-risk infant's discharge from a NICU. Preparing for discharge. In the past, preterm infants often were discharged about the time of their expected birth. However, many infants now go home before their due date. It is important that the parents understand the expected hospital course. Begin early to teach parents and other caregivers any special procedures, treatments, and medications that the infant will need after discharge. Observe the parents as they perform care until they are comfortable and can do it safely. Praise their efforts and provide hints to make the care easier. Provide written information about home care of the preterm infant. Help the parents learn what is normal for their infant and how to recognize and respond to abnormal signs. Some hospitals have their parents spend a night or two rooming in a special parent room where they assume full 24-hour care of the infant and still have help when they need it. This helps increase parents' confidence that they can care for the infant by themselves. It also allows staff to evaluate the parents' abilities to care for the infant. In one study, the parents reported that they felt more confident in activities such as recognizing changes in the infant's condition, giving medications, and working with cardiorespiratory monitoring when they were in the NICU than when they were home with the infant. Help them practice more with these medical care activities so they know how to handle problems that might occur at home. Help the parents determine what adaptations they will need to make at home before discharge. Utility companies should be notified if the infant is considered medically fragile to ensure the family receives priority service in case of a power failure. Provision for emergency electricity, such as batteries, also should be arranged. Organize home nursing services, purchase of supplies, and delivery of special equipment before discharge if needed. Discuss what to expect with regard to care of the infant after discharge. Infants may require oxygen, cardiorespiratory monitoring, suctioning, gavage or gastrostomy tube feedings, or other treatments that parents will have to learn to perform. Many infants need feedings every 3 hours, day and night, to help them gain weight adequately. Feedings may be time-consuming, and parental fatigue resulting from sleep interruptions may be more than they expected, especially if they are parents of multiples. Infants are accustomed to the noises of a nursery 24 hours a day and may not sleep well at first in a quiet home environment. Suggest parents play soft music and use a nightlight for the first week. They should gradually eliminate these aids to avoid conditioning the infant to their use. Visitors and noise or activity may be too much for the infant at first. It should be limited. Explore with parents what kind of help they might need to meet the everyday requirements of the infant and the rest of the family. Help them identify where they might find assistance from family and friends. Reassure them that friends and family often welcome opportunities to help. The AAP and ACOG recommend the following in determining the time of discharge. Signs of readiness for discharge include a sustained pattern of weight gain, adequate maintenance of body temperature in an open bed, feeding without cardiorespiratory compromise, and stable cardiorespiratory function. Appropriate immunizations should have been given, car seat evaluation completed, metabolic screening performed, assessment of hearing, the eye's hematologic status and nutritional risk performed, and appropriate treatment plans completed before discharge. The family and home should have been evaluated. The family must have at least 2 members who demonstrate the ability to feed and provide all needed care, perform cardiopulmonary resuscitation, give medications, operate equipment, and show understanding of signs and problems and what to do about them. Primary care physician and other appropriate follow-up care should have been arranged. Help parents form realistic expectations about the infant. For example, they should know that the infant will accomplish developmental tasks such as crawling and walking later compared with full-term infants. Parents should base their expectations on the infant's corrected age. Corrected, or developmental age, is the chronologic age minus the number of weeks the infant was born early, rather than on chronologic age. Assist the parents in planning how to integrate the new infant into the family. Meeting the needs of their other children, in addition to the new responsibilities of caring for the preterm infant, is a major source of worry. Listen to their concerns about their other children and encourage siblings who do not have infections to visit if possible. Help parents prepare siblings for what they will see and do when visiting. Siblings should touch or hold the infant if possible to help them bond. Taking photographs of the siblings with the infant will help them remember their visit. Before discharge, a car seat challenge is often performed. Proper positioning with blanket rolls may be necessary because the infants may slump over, interfering with chest expansion. Some infants need car beds to allow them to ride in the recumbent position. Evaluation. Expected outcomes are met if parents visit often and interact appropriately with the infant. expressing their understanding of and comfort with the infant's needs, and take an increasingly active role in the care of the infant. Parents and designated caregivers should be able to independently provide care before discharge. Common complications of preterm infants. Complications of prematurity increase as the infant's gestational age and birth weight decrease. Some complications that occur in full-term and preterm infants, such as hyperbilirubinemia, are discussed in Chapter 24. Complications most often associated with preterm birth are discussed here. Further information about each condition can be found in pediatric texts. Respiratory distress syndrome. Respiratory distress syndrome, RDS, is a condition caused by insufficient production of surfactant in the lungs. It occurs most often in preterm infants under 28 weeks of gestation and increases as the gestational age decreases. Other risk factors for RDS include birth, asphyxia, cesarean birth, multiple birth, male gender, cold stress, and maternal diabetes because these conditions interfere with surfactant production. It is less frequent, however, when antenatal corticosteroids or chronic fetal stress, such as in heroin addiction, maternal hypertension, or prolonged rupture of membranes, causes the lungs to mature more quickly. Pathophysiology. Surfactant is a phospholipid that lines the alveoli. Surfactant decreases surface tension to allow the alveoli to remain open when air is exhaled. It must be continuously produced as it is used. Sufficient surfactant is usually produced beginning at 34 to 36 weeks of gestation to prevent RDS. When too little surfactant is present, the alveoli collapse each time the infant exhales. The lungs become non-compliant or stiff and resist expansion. Non-compliant lungs require a much higher negative pressure for the alveoli to open with each inhalation. This results in severe retractions with each breath because the chest wall is very compliant. The weak muscles of the chest are drawn inward, placing pressure on the lungs that further interferes with expansion. Seesaw respirations also may occur. As fewer alveoli expand, atelectasis, hypoxia, and hypercapnia occur. This causes pulmonary vasoconstriction and decreased blood flow to the lungs because of the high resistance within the pulmonary blood vessels. Persistent pulmonary hypertension can result in a return to fetal circulation patterns, with opening of the ductus arteriosus. Acidosis and alveolar ischemic injury further complicates the condition by interfering with surfactant synthesis. Tests of amniotic fluid can detect lecithin, sphingomyelin, phosphatidiglycerol, and phosphatidylinosytol, which are components of surfactant. These tests can predict whether the fetal lungs are mature enough for survival outside of the uterus. They are done before an elective induction or cesarean birth is performed on an infant younger than 38 weeks of gestation. The incidence and severity of RDS may be reduced by giving the mother corticosteroids before birth. Manifestations. Signs of RDS begin during the first hours after birth. They include tachypnea, tachycardia, nasal flaring, and cyanosis. Retractions of accessory muscles are common. They may be above or below the sternum and or between or below the ribs. Audible grunting on expiration is characteristic. It results from air moving past a partially closed glottis, which helps maintain lung expansion. Gas exchange during exhalation and functional residual capacity. Breath sounds may be decreased and crackles may be present. Acidosis develops as a result of hypoxemia. Blood gases show increased carbon dioxide levels and decreased oxygen levels. Chest radiographs show the ground glass, reticulogranular appearance of the lungs that is characteristic of RDS. Areas of atelectasis are present. Signs become worse, peak within 3 days, and then begin to improve gradually. Therapeutic management. Surfactant is instilled into the infant's trachea shortly after birth or as soon as signs of RDS become apparent. Doses are repeated if necessary. Infants treated with surfactant have higher survival rates, although the incidence of other complications of prematurity, such as bronchopulmonary dysplasia, is unchanged. Other treatment is supportive, including oxygen, continuous CPAP or mechanical ventilation, inhaled nitric oxide, correction of acidosis, IV fluids, and care of other complications. Antibiotics may be given because signs of neonatal pneumonia are similar to those of RDS. Low temperature and low glucose level may occur and should be treated promptly. Nursing considerations. The nurse observes for signs of developing RDS at birth and during the early hours after birth. Changes in the infant's condition are constantly assessed. Changes in ventilator settings may be necessary as the infant's ability to oxygenate increases. Observation for signs of common complications such as patent ductus arteriosus and BPD is important. The nurse should monitor the results of laboratory tests for abnormalities in blood gases and acid-base balance. Early signs of sepsis should be identified and reported. Other care is similar to general care for the preterm infant. Bronchopulmonary dysplasia, chronic lung disease. Bronchopulmonary dysplasia (BPD), also known as chronic lung disease, is a chronic condition in which damage to the infant's lungs requires prolonged dependence on supplemental oxygen. It occurs most often in infants younger than 32 weeks of gestational age and in one-third of VLBW infants. The diagnostic criteria for BPD includes gestational age, the length of time on oxygen, and the amount of oxygen needed. The common definition of BPD is when an infant requires oxygen 28 days after birth. Pathophysiology. BPD results from a combination of factors such as mechanical ventilation, high levels of oxygen, asymptomatic PDA, and infections that injure bronchial epithelium and interfere with alveolar development. The result is inflammation, atelectasis, edema, and airway hyperreactivity with loss of cilia, thickening of the walls of the alveoli, and fibrotic changes. Manifestations. The major sign of BPD is an increased need for or an inability to be weaned from respiratory support and oxygen. Other signs include tachycardia, tachypnea, retractions, crackles, wheezing, respiratory acidosis, cyanosis, increased secretions, bronchospasm, and characteristic changes in the lungs on chest radiographs. Pulmonary edema may occur. Therapeutic management. Prevention includes use of maternal steroids to reduce prematurity in RDS, minimizing exposure to oxygen and pressure with ventilation as much as possible, avoidance of fluid overload, and increased nutrition. Treatment is supportive, with antibiotics and bronchodilators as necessary, and gradual decreases in the amount of oxygen. Diuretics are given and fluids are restricted because infants are prone to fluid overload. Increased calories and protein are important. The infant may be discharged home with long-term oxygen therapy, and some need frequent rehospitalization during the first 2 years of life because of respiratory tract infections. Intraventricular hemorrhage. Intraventricular hemorrhage, IVH, is also called germinal matrix hemorrhage and paraventricular intraventricular hemorrhage. It is bleeding into and around the ventricles of the brain. Approximately 30% of preterm infants weighing less than 1,500 grams, 3 pounds 5 ounces, develop intraventricular hemorrhage. The first few days of life are the most common times for hemorrhage to occur. It may also occur in approximately 3.5% of term infants. Pathophysiology. IVH results from rupture of the fragile blood vessels in the germinal matrix, located around the ventricles of the brain. It is associated with increased or decreased blood pressure, asphyxia, or respiratory distress requiring mechanical ventilation, and increased or fluctuating cerebral blood flow. Rapid blood volume expansion, hypercarbia, anemia, and hypoglycemia are other causes. Hemorrhage is graded 1 through 4 according to the amount of bleeding. Grade 1 is a very small bleed at the germinal matrix. Grade 2, hemorrhage extends into the lateral ventricles without distension. And Grade 3 causes distension of ventricles. Grade 4 hemorrhage causes ventricular dilation and extends into surrounding brain tissue. The condition is diagnosed by cranial ultrasound through the anterior fontanelle. Manifestations. Signs of IVH are determined by the severity of hemorrhage. They may be subtle or remarkable, including lethargy, poor muscle tone, bradycardia, deterioration of respiratory status with cyanosis or apnea, drop in hematocrit, acidosis, hyperglycemia, tense fontanelle, and seizures. Therapeutic management. Most hemorrhages take place in the first week. Ultrasonography performed at 7 days of age for preterm infants at risk for IVH shows 90% of hemorrhages. If bleeding is found, serial ultrasonography may be performed to determine progression of the problem. Treatment is supportive and focuses on maintaining respiratory function and dealing with other complications. Outcomes vary depending on the severity of the hemorrhage. Of preterm infants with an IDH, 50% have no neurologic complications. Hydrocephalus may develop from blockage of cerebrospinal fluid flow. A ventriculoperitoneal shunt, catheter leading from the ventricles of the brain to the peritoneal cavity, may be necessary to drain the fluid. Nursing considerations. Many aspects of care may increase cerebral blood flow and blood pressure. These include mechanical ventilation, suctioning, and excessive handling. Even crying and changing diapers may produce changes in cerebral blood flow. Therefore, the nurse should avoid situations that may increase the risk for IVH as much as possible. Handling is kept to a minimum, and pain and environmental stressors are reduced as much as possible. Developmental care has been found helpful. Nurses are alert for early signs of IVH. Nursing care includes daily measurement of the head circumference and observation for changes in neurologic status, which may be subtle. Parents need assistance to cope with the diagnosis and their concerns regarding long-term implications. They should learn how to assess for signs of increasing intracranial pressure if their infant has IVH-induced hydrocephalus, and understand the follow-up care may include periodic ultrasound examinations. Retinopathy of prematurity. Retinopathy of prematurity, ROP, is a condition in which injury to the blood vessels in the eye leads to growth of new blood vessels that abnormally develop and may result in visual impairment or blindness in preterm infants. It occurs in up to 67% of infants weighing 1,250 grams, 2 pounds 12 ounces, or less. Pathophysiology. The exact cause of ROP is unknown, but high levels of oxygen in the blood are a risk factor. However, ROP develops in some infants who have never received supplementary oxygen. Prolonged ventilation, acidosis, sepsis, shock, IVH, and fluctuating blood oxygen levels have been associated with ROP. In ROP, immature blood vessels in the eye are injured. After a period, new vessels proliferate, extending throughout the retina and into the vitreous humor of the eye in some infants. Fluid leakage and hemorrhages from the fragile vessels may cause scarring, traction on the retina, and retinal detachment. However, the progress of pathologic processes stops in more than 90% of infants, and there is little visual loss. Therapeutic management. Infants with a birth weight of 1,500 grams, 3 pounds 5 ounces or less, or gestational age of 32 weeks or less, and selected infants with a birth weight of 1,500 to 2,000 grams, 4 pounds 6.6 ounces, or gestational age of more than 32 weeks, with an unstable clinical course, should be screened to detect changes of the eye. The frequency of repeat examinations is determined by the results of screenings. Laser surgery to destroy abnormal blood vessels is the current treatment of choice. Intravitreal bevacizumab has been used in some cases and will have more study to determine its use in the future. Cryosurgery or reattachment of the retina also may be necessary. Nursing considerations. The nurse should check the pulse oximetry readings frequently for an infant receiving oxygen. Oxygen should be titrated to keep oxygen saturation levels within prescribed limits. Extremes of high or low saturation should be avoided. Parents should be informed about ophthalmologic tests and receive an explanation of the results. Eye examinations can be very stressful to the infant, and swaddling and rest periods should be provided as appropriate. Mydriatic eye drops given to dilate the eyes may cause hypertension, bradycardia, and apnea. If surgery is performed, the eye is assessed for drainage. Ice packs may be used for edema, and pain medication should be given. Support for parents is essential throughout the examinations, and especially if damage to the eye is found. Necrotizing enterocolitis. Necrotizing enterocolitis, NEC, is a serious inflammatory condition of the intestinal tract that may lead to cellular death of areas of intestinal mucosa. It occurs in 1 to 5% of infants admitted to NICUs. The mortality rate is approximately 40%, and survivors may have long-term GI problems. The ileum and proximal colon are the areas most often affected. Pathophysiology. Although the exact causes are unknown, immaturity of the intestines is a major factor in preterm infants. The rate of NEC increases with decreasing gestational age. Previous hypoxia of the intestines may be a causative factor. The incidence of NEC is much higher after infants have received feedings. Although minimal enteric feedings are thought to increase maturation of the intestines, feedings that are too early or increase too fast may cause NEC. When infants are fed, bacteria proliferate, and gas-forming organisms may invade the intestinal wall in some infants. Eventually, necrosis, perforation, and peritonitis may occur. Breast milk, which contains immunoglobulins, leukocytes, and antibacterial agents, may have a preventative effect on the development of NEC. Studies about using prenatal steroids to prevent NEC are mixed, with some showing less and others showing greater incidence. Manifestations. Signs include increased abdominal girth caused by distension, increased gastric residuals, decreased or absent bowel sounds, loops of bowel seen through the abdominal wall, vomiting, bile-stained residuals or emesis, abdominal tenderness and discoloration, signs of infection, and occult blood in the stools. Respiratory difficulty may occur because of pressure from the distended abdomen on the diaphragm. Apnea, bradycardia, temperature instability, lethargy, hypotension, and shock also may be present. On radiographs, there may be loops of bowel dilated with air. The presence of air within the intestinal wall is characteristic of the condition. Free air in the peritoneum indicates that perforation has occurred, although perforation may occur without this sign. Therapeutic management. An increasing number of studies are showing encouraging results using probiotics as a means of establishing normal intestinal flora and preventing NEC. Mothers should be encouraged to breastfeed, especially if the infant has risk factors for NEC. If maternal breast milk is not available, donor milk can be used. Treatment of NEC includes antibiotics, discontinuation of oral feedings, continuous or intermittent gastric suction, and use of parenteral nutrition to rest the intestines. Surgery may be necessary if perforation or continued lack of improvement occurs. The necrotic area is removed and an ostomy may be performed. Infants who have had large areas of bowel removed may develop short bowel syndrome with malabsorption and malnutrition. Nursing considerations. Nurses should encourage interested mothers to provide breast milk for their infants because NEC is less likely to occur in breastfed infants. Early recognition of signs of NEC is essential to decrease mortality. Because nurses are constantly observing the infant, they often are able to detect the early subtle signs that lead to prompt diagnosis. If one or more signs are noted, the nurse withholds the next feeding and notifies the provider. Abdominal girth is measured and IV fluids and parenteral nutrition must be managed. Intake and output are important because third space fluid loss occurs when fluid moves from the intravascular spaces to the extracellular spaces. The infant should be positioned on the side to minimize the effects of pressure on the diaphragm from the distended intestines. During recovery, the nurse should observe. That's right, that's what it says. The nurse should observe for signs of feeding intolerance when feedings are resumed. Scar tissue may cause partial or complete bowel obstruction. Short bowel syndrome. Short bowel syndrome, SBS, is a condition caused by a bowel that is shorter than normal. It is caused by congenital malformations of the GI tract or surgical resection that decreases the length of the small intestines. Pathophysiology. When the bowel is too short, decreased mucosal surface area causes inadequate absorption of fluids, electrolytes, and nutrients. A loss of more than 50% of the small bowel may result in symptoms of generalized malabsorption or deficiencies of certain nutrients related to the region of bowel that has been removed. Manifestations. The most common symptoms of SBS are malabsorption, diarrhea, and failure to thrive. If the small bowel is 40 centimeters or more, the malabsorption may improve in time because the remaining bowel continues to grow and adapt in function. Therapeutic management. During surgery, every effort is made to preserve as much of the small bowel length as possible. After surgery, the child's fluid and electrolyte balance must be restored and stabilized. The mainstay of treatment for infants and children is nutritional support. TPN is begun as a primary source of nutrition. It is formulated to meet the child's nutritional needs as well as promote weight gain and growth. Enteral nutrition is begun as soon as possible after surgery to allow the intestines to adapt to food. Nursing considerations. The nurse manages the infant's TPN and enteral feedings. TPN is generally infused through a central venous access device. Strict asepsis should be used when performing central line dressing changes and when administering TPN to prevent central line associated bloodstream infections. Enteral nutrition is advanced slowly while corresponding adjustments are made to the composition of the TPN. The nurse carefully assesses and documents tolerance of enteral feedings, noting any signs of dehydration, electrolyte imbalances, and nutritional deficits. Non-nutritive sucking is provided as well. Postterm infants. Postterm infants are those who are born after the 42nd week of gestation. Their longer than normal gestation places them at risk for a number of complications. Scope of the problem. Less than 10% of all pregnancies are considered postterm. In some cases, the fetus continues to be well supported by the placenta and is of normal size or is large for gestational age. Some grow to more than 4,000 grams, 8 pounds, 13 ounces, placing them at risk for birth injuries or cesarean birth. In other cases, placental functioning decreases when pregnancy is prolonged. If placental insufficiency is present, decreased amniotic fluid volume, oligohydramnios, and compression of the umbilical cord may occur. The fetus may not receive the appropriate amount of oxygen and nutrients and may be small for gestational age. This condition results in hypoxia and malnourishment in the fetus and is called post-maturity syndrome or dysmaturity syndrome. Post-maturity syndrome occurs in about 20% of postterm pregnancies. When labor begins, poor oxygen reserves may cause fetal compromise. The fetus may pass meconium as a result of hypoxia before or during labor, increasing the risk of meconium aspiration at delivery. These infants are also at higher risk for asphyxia than are other infants. Postterm infants have a higher perinatal mortality rate than infants born at term. Assessment. Most infants will be normal at birth. If the infant is large, the nurse should observe for injury and hypoglycemia. The infant with post-maturity syndrome may have an apprehensive look associated with hypoxia. The infant may be thin with loose skin and little subcutaneous fat. The umbilical cord is thin with little Wharton's jelly. There is little or no vernix caseosa, but the infant generally has abundant hair on the head and long nails. The skin is wrinkled, cracked, and peeling. If meconium was present in the amniotic fluid, the cord, skin, and nails may be stained yellow-green, indicating that meconium was present for some time. Postterm infants should be assessed for hypoglycemia because of rapid use of glycogen stores. If loss of subcutaneous fat has occurred, the infant is at risk for low temperature. Therapeutic management. Therapeutic management focuses on prevention and symptomatic treatment. Expectant mothers who are overdue are scheduled for tests of placental functioning, and labor is induced if signs of placental deterioration are discovered during fetal diagnostic testing. If the fetus cannot tolerate labor, a cesarean birth is necessary. APGAR scores less than 7 are more likely in postterm infants. In cases of asphyxia or meconium aspiration, respiratory support is needed at birth. Nursing considerations. The nurse's role is primarily one of prevention of complications, where possible, and monitoring of changes in status. During labor and delivery, the nurse responds appropriately to fetal heart rate decelerations, prepares for and assists in emergency delivery, and cares for respiratory problems at birth. Signs of post-maturity syndrome in infants are noted during the initial assessment. Respiratory problems may necessitate continued assessment and care. Infants with any indications of post-maturity should be tested for hypoglycemia soon after birth and again an hour later or according to hospital policy. They need early and more frequent feedings to help compensate for the period of poor nutrition before birth. Temperature regulation may be poor because fat stores were used for nourishment in utero. Providing extra blankets, assessing temperature frequently, and teaching parents about prevention of cold stress are important throughout the hospital stay. Polycythemia resulting from hypoxia before birth increases the risk for hyperbilirubinemia. Small for gestational age infants. Sga infants are those who fall below the 10th percentile in size on growth charts. They have failed to grow in the uterus as expected and have FGR. Some infants who do not meet the definition for Sga may have FGR and fail to grow to full potential before birth for a variety of reasons. However, the terms Sga and FGR often are used interchangeably. Sga infants may be preterm, full-term, or post-term. Infant mortality and morbidity increase steadily as growth restriction increases. Approximately 1/3 of all LBW infants are Sga. Causes. Many risk factors may cause an infant to be Sga. Congenital malformations, chromosomal anomalies, genetic factors, multiple gestations, and fetal infections such as rubella or cytomegalovirus may cause FGR. Poor placental function resulting from aging of the placenta, small size, separation, or malformation may interfere with fetal growth. Illness in the expectant mother, such as preeclampsia or severe diabetes, restricts uteroplacental blood flow and decreases fetal growth. Smoking, drug or alcohol abuse, and severe maternal malnutrition also impair fetal growth. Scope of the problem. Infants affected with FGR have higher perinatal morbidity and mortality rate that is 10 to 20 times that of infants who are not growth restricted. Death may occur from asphyxia before or during labor because of poor placental functioning or from complications of congenital anomalies or prematurity. Full-term Sga infants are subject to many of the same complications as those who are preterm or post-term. Problems tend to be greatest in infants who are preterm in addition to being Sga. Low APGAR scores, meconium aspiration, and polycythemia are increased in the Sga infant. Hypoglycemia is common because of inadequate storage of glycogen in the liver. Although mature muscle tone enables the Sga infant to maintain better flexion than the preterm infant, Sga infants are prone to inadequate thermoregulation because subcutaneous white fat and brown fat stores have been used to survive in utero. If hypoglycemia develops, inadequate glucose is available for increased metabolism to produce heat, increasing the problem. Characteristics of small for gestational age infants. The appearance of the Sga infant varies depending on whether the cause of growth restriction began early or late in the pregnancy. Variation occurs because growth restriction affects the weight first. If it continues, the length and then the head size eventually will be affected. Symmetric growth restriction involves the entire body. It may be caused by congenital anomalies, genetic disorders, exposure to infections or drugs early in pregnancy, or normal genetic predisposition. Although the infant's weight, length, and head circumference are all below the 10th percentile, the body is proportionate and appears normally developed for size. The total number of cells as well as the cell size are decreased, and the infant may have long-term complications. These infants are often small throughout their lives. They have a higher rate of neonatal mortality. Approximately 20 to 30% of Sga infants have symmetric growth restriction. Asymmetric growth restriction is caused by complications such as preeclampsia that begin in the third trimester and interfere with uroplacental function. In asymmetric restriction, the head is normal in size but seems large for the rest of the body. Brain growth and heart size are normal. The length is normal, but the weight is below the 10th percentile for gestational age. The abdominal circumference is decreased because the liver, spleen, and adrenals are smaller than normal. The infant appears long, thin, and wasted. The dry, loose skin has longitudinal thigh creases from loss of subcutaneous fat. The infant has a sunken abdomen, sparse hair, a thin cord, and the facial appearance of being elderly. The anterior fontanelle may be large with wide or overlapping cranial sutures. These infants generally catch up in growth, particularly in the first 2 years, if they are adequately nourished after birth. Therapeutic management. Therapeutic management is focused on prevention, with good prenatal care to identify and treat problems early. When growth restriction cannot be prevented, ultrasound examination may permit early discovery of the condition. Serial non-stress tests and biophysical profiles help determine whether the infant should be delivered early, and preparation can be made for the expected complications at birth. Problems during and after birth are treated as they occur. They may include asphyxia, meconium aspiration, hyperglycemia, and polycythemia. Sga infants have a greater surface area and higher metabolic rate than infants who are appropriate for gestational age. This increases the risk for problems with temperature stability. Nursing considerations. Because the causes of growth restriction are so varied, care of the Sga infant should be adapted to meet the specific problems presented. When signs of growth restriction are present, the nurse should observe for complications that commonly accompany it. The general appearance and measurements give an indication of the type of growth restriction that has occurred. Measurements of the head, chest, length, and weight are below normal in the infant with symmetric growth restriction. If the restriction is asymmetric, the head circumference and length are normal, but the abdominal circumference and weight are low. The nurse should assess for hypoglycemia, especially in asymmetric growth-restricted infants. The brain of the infant is normal and needs large amounts of glucose, but the liver is small and has inadequate stores of glycogen. Caloric needs are greater than for a normal infant, making early and more frequent feedings important. Temperature regulation and respiratory support are additional nursing concerns. Observation for jaundice is important in infants with polycythemia because a large amount of bilirubin may be released when the red blood cells break down. Large for gestational age infants. LGA infants are those who are above the 90th percentile for gestational age on intrauterine growth charts. They may have macrosomia, weigh more than 4,000 to 4,500 grams, 8 pounds 13 ounces, to 9 pounds 15 ounces, and are usually born at term, although they may be preterm or postterm. Preterm LGA infant may be mistaken for a full-term infant but has the same problems as other preterm infants. Causes. Infants who are LGA may be born to multiparas, large parents, mothers who are obese, and members of certain ethnic groups, Asian, Black, and Hispanic. Diabetes in the mother also may cause increased size, as may erythroblastosis fetalis. Scope of the problem. The LGA infant is more likely to go through a longer labor, suffer injury during birth, or need a cesarean section. Shoulder dystocia may occur because the shoulders are too large to fit through the pelvis. Fractures of the clavicle or skull, injury to the brachial plexus or the facial nerve, cephalohematoma, subdural hematoma, and bruising occur more often in these infants than those of normal size. Congenital heart defects and a higher mortality rate also are more common. Therapeutic management. Therapeutic management is based on identification of increased size during pregnancy by measurements of fundal height and ultrasound examination. Delivery problems may lead to use of a vacuum extractor, forceps, or cesarean birth. Birth injuries and complications are treated as they arise. Nursing considerations. The nurse assists in a difficult delivery or cesarean birth resulting from dystocia when the infant is LGA. After birth, the infant is carefully assessed for injuries or other complications such as hypoglycemia or polycythemia. Nursing care is geared to the problems presented.